Radiation exposure can also lead to lymphatic blockage. Okay, this is the Bowman space, and this is the glomerular capillaries. So we are having hydrostatic pressure of the glomerular capillaries GC right now, and we have hydrostatic pressure of the Bowman space, and then we have oncotic pressure of the Bowman space, and we have oncotic pressure of the glomerular capillaries. We know that oncotic pressure is the pulling pressure and hydrostatic pressure is the pushing pressure. So they opposite, right? And that's what actually is going to favor the filtration. As the hydrostatic pressure of the glomerular capillaries predominates, it favors the filtration.
Step Excel Rapid Recall.
Let's say, for example, if the individual is having obstruction when you talk about, like in the case if somebody is having BPH, or individual is having renal stones, or let's say there is some cancers, bladder cancers or something, then what happens? The pressure backs up, isn't it? And what happens is your hydrostatic pressure of the Bowman space starts rising. This hydrostatic pressure, which is opposing the hydrostatic pressure of the glomerular capillaries, isn't it? Right? So what happens? This will decrease the GFR, isn't it? Because it is opposing, isn't it? So that will decrease the glomerular filtration rate. In post-renal azotemia, secondary to BPH, remember in BPH, the periurethral zone that is getting narrowed, or renal stones, obstruction more distally. Imagine if there is going to be obstruction at the level of the bladder, right? And that can back up both side ureters, bilateral hydronephrosis can occur, right? And then remember, there is going to be elevated BUN and creatinine. But please remember, the ratio is not significantly rising. The ratio is usually still less than 15.
Step Excel Rapid Recall.
Yes, BUN rises, yes, creatinine rises, but the ratio is still maintained less than 15. Remember, it usually varies. Why it varies? Because if you recall, I told you in the prerenal azotemia, remember that urea can back up into the body. So BUN, urea can back up. Remember, urea absorption is flow dependent. Urea absorption is
flow dependent.
So that means if there's going to be increase in flow, that means decrease urea reabsorption. That is inverse. Whereas there's a decrease in flow, there's an increase to urea reabsorption. That's what's saying. Where the reabsorption is happening, it is in the proximal convoluted tubule. Prerenal azotemia, recall, prerenal azotemia was due to congestive heart failure, individual who is having hemorrhage, blood loss, right, or dehydration, very classic. There's a question in your NBME also, we will discuss about it later, but dehydration. So imagine if there is, this is the afferent and this is the efferent arteriole, and if you are decreasing the flow, when you decrease the flow, less filtration, and less filtration, that means more urea backs up into the body. So there are three simple classifications. There is going to be a prerenal azotemia, there is an intrinsic renal azotemia, and then there is going to be a post-renal azotemia.
Step Excel Rapid Recall.
Prerenal is before, intrinsic renal is within, and post-renal is after. Prerenal is the problem here. Intrinsic renal is the problem here.
Not in the Bowman's capsule, but in the PCT?
Yeah, in the tubules. For example, patient is having acute interstitial nephritis or acute tubular necrosis. So these conditions are associated with intrinsic. Intrinsic means within it. Intrinsic means within the tubule. There's a problem, okay? You can also say the patient is having low albumin. So hypoalbuminemia, liver failure can also be there because of oncotic pressure, right? So that is less fluid that is delivered to the kidney, right? So CHF patients, right? Patients who are having shock, hypovolemic shock, and so on. That is a prerenal. I just now mentioned that the post-renal azotemia, which could be associated with BPH, tumors, and renal stones. What we notice in the intrinsic renal azotemia, it is associated with acute tubular necrosis, acute interstitial nephritis, glomerulonephritis, conditions which are associated with vasculitis disorders, MAHA conditions like TTP and US, right? That is thrombotic thrombocytopenic purpura and hemolytic uremic syndrome. There are various different toxins and drugs can also lead to intrinsic renal azotemia. Now, the basic idea in the prerenal azotemia is that when there is less filtered load, I told you, increased urea absorption. Remember that you're not getting rid of the creatinine as well. Creatinine is some secreted. Oh, increase in BUN and creatinine ratio, which is greater than 15. Now think about it from the perspective. Kidneys, they are responsible to regulate the flow. They are responsible to regulate the pressure. How much is the fluid present or the filtered fluid present?
Step Excel Rapid Recall.
Remember that there is a sensor which is called as a macula densa. I will discuss about this in the context of cumuloglomerular feedback. But the point is that macula densa is a sensor. It senses the sodium chloride, and on the basis of that, it is responsible to dilate or constrict via prostaglandins, because prostaglandins are the dilators in the afferent arteriole, and on the basis of that, you can manage and regulate the blood flow. But the point is that when there is going to be prerenal azotemia, less fluid delivered, the kidneys are going to compensate to bring more and more water back into the body. Now, what will happen in this case? There is going to be maximally concentrated urine. Basically, more and more water will come back into the body, and the urine osmolarity will be more or less.
Less.
Okay, think about it. If kidneys are analyzing that there is less fluid delivered here, isn't it? Less fluid delivered, that means what they should do, they should bring more water back into the body, yes or no?
Yes.
Yes, they will try to absorb maximum amount of water, making the urine similarly concentrated, right? So urine osmolarity will be also greater than 500 milliosmoles a kg, right? Remember, the urine sodium concentration will be also lesser. Urinary sodium less than 20 milligallons per liter, because remember, if the sodium is coming back into the body, water follows sodium. That's our goal, right? And that's why we are decreasing the excretion of sodium, which is what is called as a FeNA. Fractional excretion of sodium is less than 1%, because I don't want to lose the sodium from the body, because water will follow sodium and retain it.
Step Excel Rapid Recall.
So just to keep in mind that the BU creatinine ratio, I gave you 15 value. It can be, some books they refer first aid, it refers 20, Gaulian refers 15, and I'll go with Gaulian, and which greater than 15 is the BU creatinine ratio. Intrinsic renal azotemia, when you talk about, this problem is within the tubule itself. Now think about it. No matter how much I try to reabsorb, the GFR is also affected. Loss of water and sodium, isn't it? So sodium and water which is lost, that means urinary sodium will be more or less
More.
greater than 40. Yes, almost greater than double. You can remember like that. Fractional excretion of sodium, FeNA. FeNA is also greater than 2%. Okay, 2.5 or 2%. You can remember like that. And last, the osmolarity of the urine will be less than 350. Why? Because water is also lost from the body.
Step Excel Rapid Recall.
But BU and creatinine ratio is going to be less than 15. Why do you say it is less than 15? Because although BUN is rising, although creatinine is rising, but the ratio is less than 15. Why? Since BUN or urea is retained, creatinine is also retained in the body. Okay? And then last comes is the post-renal azotemia. In post-renal azotemia, the obstruction of BPH or renal stones, right? This is going to vary. Why it is going to vary? Think about it. Imagine if there is going to be an obstruction, there is a decrease in GFR, isn't it? Because already the hydrostatic pressure of the movement space is high. In the beginning, what happens? There is going to be backing up. Patients are having, let's say, posterior urethral valve, right? Which is a boy, baby, a newborn, let's say posterior urethral valve. Now, when there is a backing up, in the beginning, what happens? Urea comes back into my body. In the beginning, the BUN and creatinine ratio in the beginning is high. If you want to refer, you can refer to Gaulian pathology in this, right? BUN creatinine ratio is going to increase in the beginning, and then later on, BUN creatinine ratio starts going down. Why? Because now the tubular epithelial cells are getting damaged. Once it is getting damaged, they slough off, and there is, again, the manifestations that mimic intrinsic renal, isn't it? It's just like intrinsic renal now. So usually it varies. That's why they're not going to test you this for BPH or renal stones. That is an example of post-renal azotemia. But just wanted to mention, if I'm going to constrict or dilate, the efferent or efferent arteriole, what will be the outcome? The examiners love to go after this, and you have to remember, because they will test you in the context of filtration fraction and GFR.